research and establish new networks and enabling collaboration on major research topics for experienced researchers and higher degree students. Next slide, please. So how do we fit within FIP? We belong to the Board of Pharmaceutical Sciences, or BPS, which deals with FIP's scientific activities with the ultimate objective of contributing to the improvement of world health, mainly through disease prevention and treatment strategies. Within the BPS, there are 6 special interest groups, and as you can see, Pharmacy Practice Research SIG is one of them. Next slide, please. We would love to have you on board, so you can engage with the PPR SIG through individual membership of FIP. Also, you can interact with us through different activities that we organize on a yearly basis, on a regular basis, mostly through our face-to-face events and also digital events. We also have a large group of researchers who interact through our Facebook group, which you can become a member of, as you can see on the slide. We also organize different webinars and also events like the one we are having today and tomorrow. We organize summer meetings virtually or also face-to-face, and I'm very glad to announce that our next place meeting will be in Copenhagen, probably before the FIP World Congress in 2025. Next slide, please. For today, we have a very exciting program, as you can see on the slide, and we will have different researchers across the world presenting their research. For today, we have 7 researchers. We will have time for presentation and also Q&A session, so feel free after their presentation to put your questions on the Q&A chat box, and we will be able to interact with your questions. We will also have a coffee break at 2:30 p.m. Central European Time. Next slide, please. After tomorrow, we will have some awards for the best presentations, and we will also have awards for the best poster presentations. Next slide, please. It is very exciting to announce that we have e-posters available, and you can access all of them via the website. We also have other modes of accessing the e-posters, as you can see. So to access the posters, next slide, please. You just have to type on Google PPR SIG 2024, and the first result that comes on the search, click on that, and it will bring you to our website for this event. Go to e-posters, and then you will see the different posters available with the title, the author of the poster, and also the abstract associated to its poster. Feel free to interact, access all those posters, have a look at them during the coffee break, and also you might be able to reach the authors and interact and establish new networking collaborations. Next slide, please. You can also access the e-posters through our app. I will explain how you can access. So you can see the QR code, depending if you have Android or Apple. So if either of those options are available, just scan the QR code and it will bring you to, if you go to the next slide, please, to the app which you can download. Please make sure that you are selecting the one with the logo on the screen. It will be necessary to introduce a code, which is PPR SIG 2024 VIR. Next slide. And I will give the floor to our Vice Chair, Charlotta Rosin from Denmark, which will be moderating the different research presentations for today. Thank you very much.
Thank you very much, Victoria, and thank you for giving me the opportunity to present today or to facilitate the different very exciting speakers that we have today. We are very happy to see so many engage with this meeting, and it's really exciting for us. The first presenter will be Emma. She's from the University of Granada, where she's passionate about the field of pharmacy and the fact that she can help improving patient outcome and develop effect and sustainable services. She's doing a PhD right now, which she will be presenting from, where she's focusing on facilitators and barriers in the implementation of community pharmacy services and minor ailment schemes. I'm very glad to welcome Emma here, and please let us hear about your research.
Thank you. Can you see my slides?
You need to put it in presentation mode.
Yeah, but they are visible, right? Okay.
Yes, they are.
Thank you. Thank you so much. Okay, well, good afternoon. My name is Emma Graham, and I'm a PhD student at the University of Granada. And I'm currently at Robert Gordon University in Aberdeen as a visiting PhD researcher. Today I'm going to talk a bit about my research on tailoring implementation strategies for overcoming health service provider barriers. So firstly, I would just like to say that I have no conflicts of interest to declare. So what is implementation science research? Well, it is the scientific study of methods that promote the uptake of both research findings and evidence-based practices in a systematic way. So this is done in order to get this research and these practices into routine practice. And this is done in order to improve the quality and effectiveness of health services and care. Now, it has been shown that implementation of this research and these practices in healthcare is overall a complex process in which a type of implementation factor known as a barrier comes into play. These barriers are factors that hinder this implementation process, and they can sometimes even cause the implementation of the research or the evidence-based practice to fail. So here in this figure on the right-hand side of the slide, we can observe these factors, these barriers, and in the context of community pharmacy, we can see that they have multiple layers or domains depending on where the factor has been identified. So for example, again, in the context of community pharmacy, the barrier could pertain to the professional service being implemented, to the pharmacy staff themselves, to the pharmacy where the innovation is being implemented, or even to the local environment and the system within which that community pharmacy is. So in order to overcome these barriers that are contained within these different layers, implementation strategies can be used. An implementation strategy is an action taken to enhance that adoption, that implementation, and its sustainability of the evidence-based intervention. When these strategies are designed specifically for a certain barrier, these strategies are known as tailored implementation strategies. So one of the ways that these barriers can be classified is using a determinant framework. An example of a determinant framework is the Consolidated Framework for Implementation Research, or CIFA. This consolidated framework for implementation research groups these barriers into 5 domains, and then again into 48 constructs. And then they add an extra 19 subconstructs, which really adds another layer of complexity to this framework. So therefore, if you were to code barriers to this framework, these barriers being identified could refer to the characteristics of the healthcare providers, for example, the pharmacists themselves, or the individuals that are implementing the innovation. They could also refer to the inner setting or the care center or the pharmacy. They could refer to the outer setting, which would be the patients, other centers, etc. And it could depend on the innovation being implemented itself or the process that's being carried out, the implementation process. So as an example, a lack of motivation of the healthcare provider would be classified within the individual's domain, whereas the complexity of the innovation being implemented would be classified to the innovation domain here. So similarly to the barrier classification, there are several taxonomies that are used for implementation strategies, one of which is the expert recommendations for implementing change taxonomy, or the ERIC taxonomy. This taxonomy also includes broad groups, in this case 9, within which the 73 strategies are grouped by similarity. This categorization was achieved after the researchers carried out a concept mapping process. So again, just for it as an example, developing resource sharing agreements, for example, has been sorted into the support clinicians category represented here in orange. So why is this study important? Well, facilitating implementation using these strategies that we've mentioned has seemed to be an effective approach. And although some barrier strategy selection tools have been developed, really the real world effectiveness of these strategies is very limited. Therefore, what we wanted to do was to identify research in the literature linking these real world barriers and their strategies and the effectiveness of these strategies when practicing healthcare providers were implementing evidence-based practices. So this review was undertaken and reported in accordance with the preferred reporting items for systematic reviews and meta-analysis, PRISMA statement and guidelines. The study quality data was extracted using the appropriate critical appraisal skills program CASP checklist. And then we also designed both inclusion and exclusion criteria with the aim of including original research that linked barriers to strategies and their outcomes during processes in which these innovations for practicing healthcare providers were being implemented. However, we also decided to exclude certain type of or certain publication types, such as reports or protocols and conference abstracts. We also decided to exclude papers that linked barriers, strategies and outcomes anywhere in the paper or the article except the results section. So we searched 5 databases up until currently February 2023, and this will be updated until May 2024. And these databases were PubMed, Scopus, Web of Science, PsycInfo, the Cochrane Library, and these search terms involved related to barriers to implementation, the implementation strategies, and associated terminology. So after these searches were carried out, articles were then screened by title and by abstract, and the inclusion-exclusion criteria were applied to identify eligible studies for the review. So once we had applied those inclusion and exclusion criteria, the included full text articles were then reviewed in order to extract the barriers, the implementation strategies, and their outcomes. The barriers were then coded using the Consolidated Framework for Implementation Research, or CIFA's, menu of constructs, and implementation strategies were coded using the ERIC taxonomy. So additionally, to guarantee the review's quality, 10% of that coding was then independently verified by a second researcher. And if there was any disagreement between the two, the coding would then be discussed and a consensus would be reached in order to establish that final coding. So what were the results? So firstly, as you can see here from the PRISMA flowchart, over 7,000 articles, specifically 7,024, were identified from the 5 databases. So again, PubMed, Scopus, PsycInfo, Web of Science, and the Cochrane Library. We then removed just over 1,200 duplicates, so about 1,220 duplicates, and we ended up with 5,804 distinct articles to review by title and by abstract, excluding through this process another 5,299 articles. And that left us with just over 500 articles, 505 specifically, to download the full text and apply the inclusion and exclusion criteria. Once that was done, the 52 studies that were finally included in the review, and we excluded 453 of those full text articles. So of these 52 finally included articles, we found that although we had at least one paper from each major continent, almost 60% of these were carried out either in the United States of America or in Australia. We also found that in half of these included articles, rather than just focusing on one type of healthcare professional, the researchers would involve lots of different healthcare staff in these implementation processes. Furthermore, when analysing the outcomes of the implementation strategies, we found that over 60% of these outcomes were reported qualitatively, with the remaining 38.5% reporting only quantitative outcomes for these implementation strategies. So as for the identified barriers, the two most frequent barriers that we found were related to the deliverer's characteristics. So specifically, the deliverer's capability, which would be their competence, knowledge, skills needed to fulfill that deliverer role. And then we also found barriers relating to the deliverer's opportunity, which would be their availability, their scope, their power to fulfill, again, that role. Now, to overcome these barriers, what we found in the literature was the following. So regarding their competence, their knowledge, and their skills, educational meetings were conducted within which the healthcare providers were educated about the innovation being implemented. Whereas to try to overcome the deliverer's issues regarding their availability, their scope and their power, or the deliverer's opportunity, what happened was that leadership were involved, which would be to mandate change according to the ERIC taxonomy. And implementers would try to identify ways to adapt the innovation to local requirements or to promote adaptability. So if we take that last correlation, so deliverer's opportunity linked to mandate change and promote adaptability strategy, an example of that when thinking about implementing an innovation within community pharmacy could be the following. So it could be that the barrier that the pharmacist has is that they're trying to deliver a new service that is being implemented into their pharmacy, but they haven't got time or the availability to do this. So according to the literature, two implementation strategies that could be used in order to overcome this would be to, one, involve the pharmacy owner in the implementation process, so that the implementation of the service really becomes a priority within that pharmacy. Or two, the elements which are flexible within the service that is being implemented are tailored really to meet the local needs of that pharmacy and that pharmacist, effectively promoting adaptability. So what can we conclude from this? These preliminary results really are suggesting that the characteristics of the healthcare innovation deliverers seem to be the most frequent barrier when implementing these innovations. And what we're seeing is that the frequently used real-world ERIC strategies for addressing the CIFA barriers are conducting educational meetings, mandating change, and promoting adaptability. So further analysis, within which the systematic review will be again updated until May 2024, will additionally evaluate these real-world implementation strategies' effectiveness. And this will allow us to provide recommendations for tailored strategies to barriers, which hopefully will simplify the strategy selection process for future implementation studies in healthcare. So thank you very much for listening. And if you have any more questions or comments, please don't hesitate to contact me through my email addresses here. Thanks again.
Thank you very much, Emma, for your wonderful presentations. And now I would like for all of the participants, if you have any questions for Emma, please go to the Q&A box, and then you can type in your question, and Emma will be very happy to answer any questions that you have there. Thank you for sharing your very important research again, Emma.
Thank you.
And then I would like to move on to the next, a lot of parts and clapping hands going on to Emma. I would like to move on to the next speaker, which is Federico Basilio from the University of Minnesota, the College of Pharmacy. He's a PhD candidate in social and administrative pharmacy at the university. His experience including leading quantitative, qualitative, and mixed methods studies in community pharmacy services and organizational culture. He also has expertise in designing and implementing evaluations and qualitative improvement processes to translate scholarly evidence into stakeholders' adapted interventions in pharmacy education, and in-person and online teaching experience in addressing socioeconomic disparities and health literacy. His background includes diverse industry experience across regulatory and medical affairs, where he helped obtain and maintain special drug approvals and interpreted data from randomized controlled trials and observational studies to write scientific summaries and educate physicians, pharmacists, and clinical researchers. His career goal is to establish himself as a mixed method researcher and an evaluator to improve pharmacy practice and education. Thank you very much, Federico, and we are looking forward to hear your presentation. Please.
Hello, everyone. Let me share my screen. Oh, okay. So, yes. Hello, everyone. This is a presentation on using Leadership Circle to promote leadership development. And this program and this study was conducted. It was a multi-institutional study, and it was conducted by several pharmacy professors across colleges of pharmacy in the United States. There were no conflict of interest to disclose, so let's move on to the background. Good. So in pharmacy academia, leadership is a skill that faculty and administrators develop over time. Developing leadership skills, it's not easy though. It's a longitudinal and complex endeavor, and it requires much more than just attending workshops and seminars about theories and model. But at some point, aspiring leaders, they have to stop just talking about leadership and actually doing leadership. However, it's difficult to achieve during traditional leadership development programs that are typically offered by institution or professional organizations. In response to this, the Leadership Development Special Interest Group at AACP, the American Association of Colleges of Pharmacy, developed the Leadership Circle program, LC. This program was created to offer a non-traditional participatory leadership development program that provides an accessible, engaging, and flexible approach to leadership development. Members participating were allowed to practice leadership skills and apply frameworks to address real-life leadership challenges. And so to improve our understanding of this program and better understand its potential, these study objectives were to explore the mechanism supporting the LC program and also explore its anticipated and unexpected outcomes. let's talk about the methods and specifically how the program was designed and delivered. So the goal of the program were to address real-life leadership challenges, apply leadership framework, seek advice and provide feedback, and also expand networks. Participants were recruited from the Leadership Development Special Interest Group, AACP, and were convened by faculty who had previously participated in a leadership circle program. The structure of the circle was 1 hour virtual meetings with 6 to 7 members each, including advisor with experiences. And participants, each meeting were assigned to a different role and different responsibilities where they had to consult and address a leadership challenge, which is referred to as the case. As you can see in the figure, there are 2 types of activity. In yellow, we have the asynchronous activity, which involved some pre-readings and pre-works for members, and specifically members were provided with description of roles, program structures, and also leadership frameworks. We have the adaptive change, which is a leadership framework developed by Hives. We had with the organizational change management by Color, and also the strength-based leadership by REF. And then also, as an asynchronous activity, there were questions to address during the post-debrief session. In blue, we also have a synchronous activity, which is the actual circle, like the leadership circle program. So basically, a typical 1-hour meeting would start with a chairperson facilitating the group and introducing the members. Then we have the case presenter. The case presenter had to describe the leadership challenge to the other members. Then we have consultant. Consultant were using those 3 leadership framework to apply those and address the leadership challenge. And then we also have observers who provided like an external perspective on how to address the leadership challenge. And then, as you can see, the chairperson closed the session and allow other members to reflect asynchronous in a debrief session. And then in the middle, we had the LC advisor who provided guidance as needed. Let's talk about the evaluation of this program. So a case study approach with a formal evaluation was conducted by 2 external evaluators. The evaluation consisted of 2 virtual focus groups with a total of 6 LC advisors. Advisors were recruited by email, and they were provided some time to prepare for the session. The focus groups were focused on gathering surprising, intriguing, and disturbing observations, and also opinion on how the LC program compares to traditional leadership programming. Focus groups were recorded and transcribed, and were analyzed by using thematic analysis. Theme development consisted of 2 phases: an initial phase of inductive coding, where the evaluators coded the transcripts and framed the coding into broader themes, and described the themes into tables with a theme heading, a description, and supporting quotes. Then the investigators came in and reviewed those themes and provided kind of an affirmation of evaluators' findings. And then finally, the evaluators review again those notes by investigators to avoid conflicts of interpretation. And then we have a second phase of deductive coding. And an established taxonomy from Lavelle was used to identify outcomes beyond traditional learning. And so identify areas that were matched to a specific outcomes. Let's talk about the results, starting from participation. We had a total of 6 leadership groups with 6 to 7 members for each group, and they met in 2022-23 academic year. Participation total was 37 members from 33 different institutions. Advisors who were interviewed reported a sense of group accountability with this idea of assigning roles in each group, providing members with a sense and a purpose for attending sessions. And sessions were perceived as gatherings with like-minded confidence instead of typical video meetings. And as you can see, an advisor mentioned that it was different than typical video meetings. Members were really involved into the leadership circle, were really focused and engaged to address this leadership challenge. As I mentioned before, we use 2 phases of coding. The first phase of thematic analysis generated 4 themes. Theme 1 was about critical components of the format. And specifically, the activity based on active learning, focused on applying concepts in real-life situation, was perceived as much better than passive learning. Advisors who were interviewed mentioned that there was realism to this experience. Members were really involved because the leadership case was not just a paper case. It was something real that people were experiencing. And they were also mentioned this applied nature of applying frameworks that was much different than just sitting and listening to something. And it felt real because this case had consequences and someone was really going to implement some of the advice. Theme 2 was about the value of the format, and specifically the virtual format promoted engagement, relationship building, and rapid learning in a low-cost, high-return on investment environment. Advisors who were interviewed mentioned that members quickly got to a point of trust where they could share confidential stuff with each other. They also mentioned that travel was not required, so it was really a cost-saving opportunity, but still there were relationship building, and this online format also made it less intimidating, and so people were more confident to share confidential stuff with each other. The third team described participant display vulnerability, effective team dynamics, and signs of psychological safety. And interviewees mentioned that the group quickly gelled and became comfortable discussing challenging issues. And it was also surprising to see a level of vulnerability and connection between members. And then we have the 4th theme, which was about the resulting growth, development, and learning from diversity of participants. Interviewees mentioned that there were some members who were new to academia, but still they were able to grow and develop into this program, even though they had a little bit of experience. And also, it was really important, the diversity and variety of different roles of the members of the groups. There were associate deans, full professor, and so it was really helpful for members to experience perspective from different roles, and this was really helpful into developing leadership skills. So then we had the second phase of coding, which was to identify outcomes beyond learning. We identified 4 outcomes. Cognitive outcome was the most anticipated because members were able to build knowledge and learn on how to apply those leadership frameworks to real-life situations. Then environment outcome was identified. And environment refers to physical and psychological surroundings where a program operates in. And can we go back to the slide? Thank you. And so basically, this virtual and flexible environment allowed to members kind of there was a lot of support, engagement, and learning. The third outcome was relationship. And there was a lot of networking and building unexpected and enduring relationships. And members also were able to build trust, bonding with each other, and eliminate some of the barriers between them. And then we have the final outcome effect. Effect was likely influenced by the three outcomes that were identified. And basically, interviewees mentioned that there were a lot of emotions and energy in the leadership groups because members were really felt like their advice was important because it was going to have an effect, and other people were going to implement some of that advice. And so there was that energy and engagement because it felt real. To conclude, the Leadership Circle program was perceived an accessible, engaging, and effective way to develop leadership skills. Members were able to practice skills and apply leadership frameworks to real-life situations. And the program was also created some of the anticipated outcomes, such as supportive and enduring relationships. So, as to conclude, the low cost needed to implement the program and the flexible virtual approach could be translated and offer a good way to develop leadership skills at the department level, college level, or national level. And the design, its simple design, can also be adapted to develop other skills beyond leadership. Thank you.
Thank you very much, Federico, for your questions. I think I will take the opportunity to just pose one question, and then afterwards, please go to the Q&A and answer any questions that will come on it. I was wondering, did you have any thoughts regarding whether this program could be used at an international level? So, I mean, because a lot of the people attending this webinar today might not have the same opportunities in their home countries. What would be your thoughts regarding that?
Yes, absolutely. As I mentioned before, it can be adapted even at an international level. We had a virtual format. And members were able to, it was flexible because members were allowed to schedule these meetings based on their availability. So it was really flexible. And when talking about international programs, there are issues with time zone, but allowing flexibility and member checking with each other about their availability could definitely be implemented at an international level. We also have time zone difference in the United States, so I really feel like it can be implemented to international audience too.
Thank you very much. And I'm also thinking about the topics, because the topics that you share in your network, would they be national specific, or would they be more generic?
Yes, so the topics were actually cases and leadership challenges that this professor were actually experiencing at their institutions. So the context was United States and national, but similar issues may be present also in Europe or in other continents and countries. So I feel like it could be a really good opportunity to learn from others.
Okay, thank you very much. I can see that a few questions came into the Q&A, and I'd like to thank you for participating. Thank you,
Thank
Frederick.
you, appreciate it. Bye.
And then I will go on to introduce the next speaker we have today. That is Jasmin Theresa Stoll. She's from Austria, where she studied pharmacy in the University of Innsbruck. After finishing her studies, she gained some industrial experience during her internship in Basel, Switzerland. When she came back to Austria, she worked in a community pharmacy and became a licensed pharmacist. Due to her strong interest in research, she decided to pursue an academic career and started to study for a doctor of clinical pharmacy, and thus became the first clinical pharmacy PhD student in Austria. Her research focused on the development and implementation of national competency frameworks for hospital pharmacists in Austria, which helps provide further education for pharmacists to expand hospital pharmacists' rights and to fulfill the patient safety goals of a WHO Global Patient Safety Action Plan starting from 2021 to 2030. Jasmin, please.
Well, thank you for the kind introduction. Hello, everyone, and thank you for the opportunity to present my study today about the development and establishment of a national hospital pharmacy competency framework for hospital pharmacists in Austria. As it was already mentioned, my name is Jasmin Stoll, and I'm a third-year PhD student at the University of Innsbruck in Austria. Next slide, please. First of all, I want to state that I don't have any conflicts of interest to declare. Next slide, please. This multi-method study is part of my PhD, and it consists of 4 phases. First of all, a systematic review was conducted, followed by discursive analysis and mapping of competencies. Afterwards, a validation process took place, and after that, an interview study was conducted. The overall aim of this study was to develop and establish a customized clinical pharmaceutical competency framework for hospital pharmacists in Austria to support their further development. Next slide, please. The protocol of the systematic review was registered with Prospero, which is the International Prospective Register of Systematic Reviews, and the preferred reporting items for systematic reviews and meta-analysis, also called the PRISMA checklist, was later used for reporting. 48 websites of pharmaceutical and/or medical organizations, plus 6 scientific databases, such as Guidelines Central, PubMed, or Cochrane Library, were searched. They were explored for guidelines and frameworks that were published between 2012 and 2022 in the English language. 102 documents were found. Title, abstract, and full text screening was conducted by 2 researchers independently, and in case of discrepancies, a 3rd researcher was consulted. Documents were excluded if they did not match our previously set inclusion criteria. In the end, 28 documents were found eligible. They were assessed for their quality using the appraisal of guidelines for research and evaluation, also called the agreed-to checklist. Data were extracted using a data extraction form. Next slide, please. So we took the CTF, the Common Training Framework, published by the European Association of Hospital Pharmacists, as a basis for the development of our competency framework in Austria. The CTF consists of 4 domains, and it summarizes competencies, which consist of a set of behavior competencies. So out of the documents we have found, 379 behavior competencies were identified. We excluded 354 duplicates, as well as 6 behavior competencies regarding community pharmacists. This process was done by 1 researcher and checked by 2 other researchers independently. In the end, 19 additional behavior competencies were identified, and they were reviewed for their contextual national appropriateness by discursive analysis. They were then mapped and added to the appropriate CTF domains, and where no CTF domain was appropriate, they were added to the domain Other. Next slide, please. So a validation process took also place by expert panel discussion. The expert panel consisted of the 4 board members of the Austrian Association of Hospital Pharmacists. They were contacted via phone and asked if they want to participate in this discussion, and they were provided with study details. They got the framework via email, and after they had time to extensively look through the framework, we held an online Zoom meeting and discussed their suggested changes. Consensus was reached for every suggested change. Unfortunately, we don't have enough time to go through all of the suggested changes and their solution, so I would just want to point out a few of them. So if you could just maybe press the next, thank you. So we discussed about the difference between seamless care and transfer of care, as these terms are pretty similar and this might be confusing. So we added for the competency framework for seamless care a comment that the focus is on medicine management, and for transfer of care, the focus is on communication. Next circle, please. So we also discussed about pharmacist prescribing in Austria, as this is not allowed in Austria yet, but we aim to include all additional behavior competencies worldwide. So we added a comment that this has to be seen within the legal authorizations in Austria, and we hope that this might be possible one day. Next circle, please. So we also discussed about the aspect of first aid. We thought of including that aspect, as first aid is mandatory by the Austrian law anyway. Next slide, please. I've also conducted an interview study. The interview study, the aim of this interview study was to get the views and opinions of key healthcare professionals in Austria about the possible implementation of a competency framework for hospital pharmacists. So the topic guide was developed based on the Consolidated Framework for Implementation Research, also called CFIR. And we did not only use this to develop the topic guide, but we also used it to underpin and structure the whole study. So as Emma has already explained the CFIR in detail, I will just go quickly through it. So the first domain is regarding the innovation, in our case, the competency framework. The second domain is about the outer setting, and in our case, for example, the healthcare system. The third domain regards the inner setting, for example, hospital. The fourth domain is about individuals and their roles and characteristics. And the fifth domain is about the implementation process and its related activities and strategies. And there's also an additional outcomes addendum. Next slide, please. So for the interview studies, key healthcare professionals were recruited. They were part or were representatives of important healthcare institutions in Austria, such as the Ministry of Health, the Austrian Chamber of Pharmacists, or the Austrian Chamber of Physicians. By purpose of sampling, we were able to recruit 22 key healthcare stakeholders, 2 for the pilot phase and 20 for the main study. After the pilot phase, the topic guide was updated. We contacted them via phone first and asked if they were interested to participate in the study. If they said yes, they got an email with a consent form, study information sheet, and a form about their demographic background. If they were still willing to participate, they had to fill these forms out and send them back to us. They then got an invitation for the interview with a specific date and time, and then the interview was held in person. Interviews were audio recorded and afterwards transcribed verbatim. I used the CFIR domains and subdomains for coding, and coding was not only done by me, but also by a second researcher. And in case of discrepancies, they were discussed. In case of no agreement, a third researcher was consulted. And I further analyzed the interviews using thematic analysis. Next slide, please. So these are the themes and sub-themes that arise using thematic analysis structured by the CFIR domains. Themes ranged from the advantages of the innovation to the skills and knowledge of hospital pharmacists to, for example, the implementation process. A sub-theme which I would especially want to point out is regarding the competition between healthcare professionals, as this was mentioned by most of the participants. Next slide, please. So Interview Partner 13, for example, said that other professional groups might see this as a competition and that they might be against the competency framework as they have the feeling that hospital pharmacists are getting into their areas. Interview Partner 14 said that this one was a bit more experienced with hospital pharmacists on board, and he or she said that in the beginning they had some problems between physicians and hospital pharmacists that was visible and noticeable, but the more or the longer this went on, the more these boundaries vanished and the more they started to trust each other, and that it was more of a familiarization process. Interview Partner 5 mentioned that physicians are at the top of the healthcare pyramid, and if somebody else, for example, a hospital pharmacist, is even at the same level as them, that this might somehow be a degradation of the medical profession and that it might seem as a loss of power to them. Nevertheless, Interview Partner 4, who is him or herself a physician, said that it would relieve them of a lot of stress and it would be an absolute benefit for them regarding quality improvement and patient safety. So he or she is absolutely in favor of implementing a competency framework for hospital pharmacists. Next slide, please. This figure summarizes factors regarding possible framework implementation, structured again by the CFR domains. So green stands for factors that might positively influence framework implementation, red stands for factors that might hinder the framework implementation, and gray is a neutral description of a situation. So regarding the innovation, participants stated that they think the competency will improve patient safety, it will improve the quality, and it will help to reduce the workload of physicians. Furthermore, they think that hospital pharmacists will benefit, as well as other healthcare professionals, institutions, and hospitals themselves. When it comes to the outer setting, participants were concerned about the attitude and acceptance of physicians towards hospital pharmacists. And regarding the implementation process, they said that they find it hard to find a starting point or an initial contact person for implementation. So overall, they are in favor of the innovation and they know about its advantages, but when it comes to certain aspects of the outer setting or especially implementation process, there might be some difficulties. Next slide, please. So to sum up, it's possible to say that participants are generally having a positive attitude towards framework implementation, and that better interdisciplinary working, as well as the attitude and acceptance of other healthcare professionals towards hospital pharmacists, might be two interesting factors worth having a second look at. At the moment, the competency framework is discussed by the Austrian Association of Hospital Pharmacists and the Austrian Chamber of Pharmacists, if it could be used as a basis to form a delegation law, which would mean that hospital pharmacists would then be able to work under the delegation of a physician, and this would mean that they are able to take over certain tasks. Regarding papers, I have summarized the first three phases, so the systematic review, the discursive analysis and mapping of competencies, as well as the validation process as a paper, and have submitted it to the International Journal of Clinical Pharmacy, and this will hopefully be accepted and published soon. And I'm also planning a paper about the interview study. Regarding our future steps, so the competency framework is now going a more political way, which we can hardly influence. So my research team and I thought of a study that helps us to obtain the beliefs of other healthcare professionals and patients about the capability and motivation of hospital pharmacists that might influence their interdisciplinary role profile development. And we hope that with this study, we can contribute even more to the development of hospital pharmacy in Austria. Next slide, please. So thank you very much for your attention. in case there is not enough time for questions, please feel also free to write me an email or use the question function. Thank you very much.
Thank you very much for your wonderful talk and your insights into the competency framework. The participants, as you might see, wish you all the best of luck. I'll just go to the Q&As and see if there are any questions. Daniela says, thank you, Jasmine, for a very interesting presentation. My question is, why did you choose to use SAFER framework? I understand that there are different frameworks that could have been used. Why did you choose exactly this one?
Well, we thought that this might be the best suitable one, as this one regards more of the implementation itself. So there is another model, for example, another framework which is called FISH, and this is mainly used for pharmacy services. So as this is more about the competency framework itself and its implementation and not directly about pharmacy services, we have chosen the CFRR.
Thank you very much. And as we saw in the first presentation also, that was the same framework. So very interesting. So maybe you and Emma should get together and share your experiences. I'd just like to thank you also for a very nice presentation, very impressive work that you've done so far. I think about that the hospital pharmacy sector is quite big all over the world, and maybe next year you will be able to join the FIP conference, because there's a section within FIP just focused on hospital pharmacy, and there are some very strong researchers and very established researchers from all over the world in that particular section. So maybe we'll see you in Copenhagen next year. That would be very.
Yes, that would be very nice. Yeah,
that would be very nice. It's not too far from Austria.
Yeah, that's true.
I think it's feasible. Are there any more questions for Jasmine? Please write it in the Q&As. We'll just give it a few moments, and otherwise we will move on to the next presenter. Can you please tell me, have you reached the point of data saturation in your interview state? That's Akil Aslem that asks about that.
Well, we did not reach data saturation, as the group of the key healthcare stakeholders were quite from a lot of different sectors. So a lot of opinions and views came up. So it was unfortunately not possible to reach data saturation.
No. And why did you then stop at 20, I think? Why did you stop there?
That was more or less just, it was not about getting all opinions of all key healthcare stakeholders across Austria. It was more about getting a glimpse of the most important ones we could find. So there's no specific reason if it's 20 or 25. It was just about the glimpse and not the whole picture.
Okay, thank you very much, Jasmine, and I wish you all the best with your future research. Thank you.
Thank you very much. Thank you.
And then we will move on to the next speakers. We have a dual presentation with Satina Ho and Ceci Seyo. Satina is a graduate from the Leslie Dan Faculty of Pharmacy at the University of Toronto. She obtained the graduate degree in Library and Information Science and an education from the University of Toronto, Canada. She completed a PhD dissertation on the Ontario Institute of Studies in Education, University of Toronto, and holds faculty appointment at the Department of Psychiatry and the Leslie Dan Faculty of Pharmacy at the University of Toronto. Shihu, I'm sorry about the names and pronunciation, is a year 4 PhD student and the Leslie Dan Faculty of Pharmacy, University of Toronto in Canada. She's currently doing an advanced pharmacy practice experience rotation at the hospital. She also has experience working in community pharmacy practice settings, and she completed a research elective under the supervision of Satina Ho in the winter semester of 2024, and she is happy to share with you her research findings and patient safety climate and the Ontario Hospital Pharmacy in Canada today. Thank you very much.
Hi, everyone. Thank you very much for the nice introduction for both of us. And I'm happy to be here with Gigi to share our work in hospital pharmacies as well, but this time in North America, in Canada. With that, I'm going to pass over to Gigi to share our research findings.
Hi, yeah, just checking everyone can see my screen and can hear me.
Yes.
Yes.
Okay, great. So hi, everyone. Welcome to our presentation on exploring the patient safety climate of hospital pharmacies in Ontario, Canada. So my name is Z, and Sartina and I conducted this research at the Leslie Dan Faculty of Pharmacy at the University of Toronto. For this presentation, we have no personal or financial relationships to disclose, no real or potential conflicts of interest to declare, and this study was unfunded. So for everyone who isn't familiar, patient safety climate, sometimes used interchangeably with patient safety culture, is a general term covering an organization's overall environment and values pertaining to patient safety as currently perceived by the staff in that organization. And as you can see here on the sticky note, for our study, we define patient safety as the avoidance and prevention of patient injuries or adverse events resulting from the processes of healthcare delivery. And we define patient safety event as any type of healthcare-related error, mistake, or incident, regardless of whether or not it results in patient harm. Now, multiple studies have linked positively perceived safety climate with positive safety outcomes. It's an important measurable metric for quality care and very commonly measured using questionnaires. Yet we noticed that in the literature, there were no questionnaires looking at patient safety climate as perceived by hospital pharmacy professionals in Ontario, Canada. Given the link between safety climate and patient safety outcomes, it becomes clear that an understanding of a setting's own safety culture is the first step in improving patient care. Additionally, this data can be used as both an internal and external benchmark by having it as a baseline to measure future interventions against, as well as comparing with other patient safety climates that have been sampled internationally. So figuring out that first step became the objective of our study, which is a descriptive cross-sectional exploration of Ontario hospital pharmacy safety climate. So this was so we could really take a look at how things are in Ontario hospital pharmacies from a patient safety perspective. To put this into geographical context, Canada consists of 10 provinces and 3 territories, and our studies focus on the province of Ontario, which is Canada's second largest province, as well as the most populous province in Canada. In terms of geographical area, Ontario is larger than France and Spain combined, covering more than 1 million square kilometers. The population of Ontario is around 14.6 million Canadians, which is nearly 40% of all people living in Canada. And the capital city of Ontario is Toronto, with a population of around 3 million people. So how did we go about achieving our objective? Essentially, we administered an online Google form questionnaire to registered Ontario hospital pharmacists and pharmacy technicians from March 4th to April 7th of this year for their voluntary participation. And the questionnaire we chose to use was an Agency for Healthcare Research, or AHRQ, validated instrument, the Hospital Survey on Patient Safety Culture 2.0, or the HSOPSC 2.0, to which we added 4 Ontario-specific demographic questions as well as 1 optional free text question. For dissemination, we posted a link to our questionnaire on the following social medias: Facebook, LinkedIn, and X. And our posts were engaged with by the Ontario College of Pharmacists, which is Ontario Pharmacy's regulatory body, and the Ontario branch of CSHP, or the Canadian Society of Hospital Pharmacists, which is a hospital pharmacy advocacy association. The Ontario branch also sent our survey to their members via their email service. Additionally, we posted weekly reminders on social media that were similarly engaged with. The HSOPSC 2.0 was picked as the ideal questionnaire for our study, as after scouring the literature, we found it to be fully comprehensive yet hospital-specific. This questionnaire was made and validated, as I mentioned before, by the AHRQ, or Agency for Healthcare Research and Quality, which is an American federal agency working on improving quality healthcare. It consists of 32 composite items and 2 single items answered using a 5-point Likert scale, which ranges from strongly disagree to strongly agree, and never to always. There was always the option for participants to answer does not apply or don't know, plus 4 demographic items and 1 free text question. The 32 composite items are sorted into 10 composite groups and consist of positively and negatively worded statements. So a positively worded statement would be, during shift changes, there's adequate time to exchange all key patient care information, where a higher score would link to a positive patient safety climate perception. So does that sort of make sense? So more people agreeing or strongly agreeing that there is adequate time to exchange key patient information would result in a higher score. And then a negatively worded statement would be, during shift changes, important patient care information is often left out, where a higher score or many participants agreeing that patient care information is often left out during shift changes suggests negative patient safety climate perception. For context, the 10 composite groups evaluated using the HSO-PSC 2.0 questionnaire are teamwork, staffing and work pace, organizational learning continuous improvement, response to error, supervisor, manager, or clinical leader support for patient safety, communication about error, communication openness, reporting patient safety events, hospital management support for patient safety, and handoffs and information exchange. The two single items were overall patient safety rating and number of patient safety events reported. The free text question asked for comments on things that may affect patient safety specific to the respondent's hospital. Like I mentioned previously, additional demographic questions were added covering Ontario Health Region of Practice, hospital bed size, type of hospital, and years of experience in the pharmacy profession. Ontario consists of 6 health regions with geographical delineations based on population size. Each local health region is meant to be adapted to the geographical region they serve, but they are all under Ontario Health, which is the Government of Ontario's health agency. We also added an additional free text question by asking the respondents for their top 3 recommendations for improving patient safety in their work area. We hope to really get a better understanding of respondents' concerns. So when we got back the results from participants, the quantitative data was analyzed using % positive score and mean score. We also did subgroup analysis on the mean score with respect to demographics and thematic analysis on the free text responses. % positive score is the analysis method recommended by the AHRQ and essentially serves as a frequency measure of how often positive responses were chosen. On the other hand, mean score was calculated by recoding the Likert scale into numbers 1 to 5. We reverse coded for negatively worded statements. Unlike the % positive score, the mean score accounts for neutral responses, whereas the % positive score only considers how often respondents chose a positive response, which means neutral and negative responses were treated the same way. They were essentially excluded. For both scoring types, answers of does not apply or don't know were excluded, which in the case of the % positive score was recommended by the AHRQ. So at the end of the study period, we got 63 responses, and it might be a bit hard to see, but what we wanted to show you is that most of the respondents were pharmacists, so 3/4 of the respondents were pharmacists, as opposed to 1/4, which were pharmacy technicians. And respondents are mostly working in a hospital between 101 to 500 beds and in a general hospital. And just over half of the respondents were from the Toronto region, which, as I mentioned, is the most densely populated region in Ontario. So finally, we had an estimate of the current patient safety climate of Ontario hospital pharmacy as perceived by pharmacy professionals. I think of interest is that after calculating our % positive and mean scores for the data, our high scoring 2 and lowest scoring 2 composite groups were the same. This result shows how different analysis methods did not affect what was positively perceived versus negatively perceived. And it was good to see consistency, as this lets us have more faith in what is truly positively and negatively perceived by hospital pharmacy professionals in Ontario. And so the top 2 were teamwork and supervisor, manager, or clinical leader support for patient safety. And the bottom 2 were hospital management support for patient safety and handoffs and information exchange. So for those wondering what the difference is between hospital management support for patient safety and supervisor, manager, or clinical leader support for patient safety, to clarify, if you take a look at the questions grouped under these domains, supervisor, manager, or clinical leader support asks the participant to consider a specific person or leader in management, as opposed to the general hospital management, which is what hospital management support for patient safety is focused on. And these strengths and weaknesses are really highlighted as like peaks and dips displayed in a radar chart. And the radar chart also shows how % positive score, which is the orange line, has more visually obvious strengths and weaknesses than mean scores, which is in blue, which may be why the AHRQ recommends using it. So for the single item measures, overall patient safety rating was positive, which we were happy to see, at a mean score of 3.08 between good and very good. And the number of events reported had a lower score of 2.16, so between 1 to 2 events and 3 to 5 events reported in the last 12 months. The major themes that came out of analyzing the free text responses supported the idea that issues with information exchange at transition points in care and hospital management support were challenges being faced. Respondents also asked for increased ease of reporting, which may be related to the lower mean score for the number of events reported. So the composite group strengths and weaknesses suggested to us that pharmacy professionals in Ontario hospitals have an overall positive perception of their collaboration and teamwork, but feel supported by their pharmacy leaders in terms of patient safety. But they also perceive overall hospital management and handoffs at transition points to be potential areas contributing to negative patient safety culture. Notably, teamwork scoring highs was consistently seen in studies from multiple other countries in the literature, such as Turkey, Ireland, and Vietnam, as well as the AHRQ 2022 database, which collects HSO PSC 2.0 data from all over the world. Interestingly, staffing and work pace, which regularly scored the lowest, including in the AHRQ 2022 database, was not seen in our study. While it still scored low in our study as the third lowest, the fact that it was not the overall lowest may be of interest from an external standpoint, where we might want to consider what Ontario hospital pharmacies are doing well in that regard and whether it is applicable to other settings. Conversely, hospital management support for patient safety and handoffs and information exchange are noticeable weaknesses not seen in international studies and seem to be unique to the Ontario hospital setting. This unique issue was triangulated in the free text analysis as well. So as you can see here, a respondent noted how they don't feel heard or supported by management, with many of their concerns being dismissed. Similarly, and I wasn't able to put it on the slide, but the issue of handoffs and information exchange was triangulated in the free text analysis as well, where a concern brought up by the respondent was the lack of cohesive communication between professions to ensure safe transfer of care upon discharge or transfer to other care units or institutions. And here I've put Healthcare Excellence Canada's Safety Competencies Framework domains. So the Safety Competencies Framework's 6 domains support healthcare providers in transforming patient safety evidence into action, as shown in the diagram. They highlight how patient safety culture is very important, sitting at the top for our end goal of enhancing patient safety, which is in the middle. But the other 5 domains, which can all be mapped to HSO-PSC composite groups, are also important for that end goal. For example, the HSO-PSC composite groups communication about error, communication openness, and response to error can be mapped to the Safety Competencies Framework domain communication. So now we'll just take a look at 2 interesting trends we saw from our subgroup analysis. Subgroup analysis showed that professionals with over 20 years of experience consistently scored the highest mean score for all composite groups, meaning they had the most positive perception of patient safety climate. On the other hand, professionals with 15 to 20 years of experience tended to score lower than their peers. Since the average pharmacy professional is between 41 to 45 years old, according to the Ontario College of Pharmacists, or OCP's most recent 2022 annual report, assuming pharmacists and pharmacy technicians begin practice upon graduation at the ages of 25 to 30, this fits the average pharmacy professional into that 15 to 20 years of experience group. In other words, it is the average pharmacy professional by age who perceives nearly all composite groups studied by the HSO-PSC 2.0 more negatively than any other age group. This could indicate a future unsustainability of the Ontario pharmacy workforce, as the average pharmacy professional has evident safety concerns, which could affect willingness to continue practicing. Another interesting subgroup analysis result was that pharmacy professionals with no direct contact with patients tended to rate higher mean scores than those with direct patient care. Notable exceptions were teamwork and response to error, which considers how the team responds to a team member's error. There were also far more safety events reported for respondents who engaged in direct patient care. This could be due to a variety of reasons, including that there may simply be more room for safety events to arise when there is direct patient care, or that there is truly a different safety culture between the 2 groups. Additionally, direct patient care may involve more or better teamwork compared to non-direct patient care pharmacy professionals. Unfortunately, this is a limitation of questionnaire-based quantitative research. We're able to see what's happening, but not necessarily why. So this leads me to our final slide, which is future directions. So in terms of what's next, we can focus on leveraging the strengths we found as a result of this study and use future qualitative studies to explore the contributing factors and develop targeted interventions for the weaknesses. For example, we could do interviews or focus groups with clinical leaders, discussing how to improve information exchange at key transition points in care. It could also help us better understand the results of our subgroup analysis. Additionally, as a general point, patient safety climate should be periodically sampled, especially after interventions, and then compared to previous samples as part of a quality improvement cycle. So what are the main points I really want you all to take away from our study? First is that patient safety climate perceived by pharmacy professionals in Ontario hospitals in Canada has some unique weaknesses in the areas of hospital management and handoffs and information exchange, which likely needs intervention. Second is that the average pharmacy professional, by age, tends to rate patient safety climate lower than their peers, and this could represent a negative trend for the future of the workforce. But overall patient safety climate was positively perceived, which we were really happy to see. So thank you everyone for your attention. These are our emails if you have any questions in the future that you think of, and our references and our acknowledgements.
Thank you very much for a very interesting presentation. Really wonderful presentation. If you have any questions, please type in the Q&As. I have a few questions while other people type in the presentation. I have two questions that goes in opposite directions. The first one is, have you had the opportunity to look at international results regarding the comparison to your results in Canada?
Yeah, so like I mentioned before, there's the AHRQ 2022 database, which like combines a lot of international data and then puts it under like one ranking system. But I also looked at individual studies from other countries, and like I mentioned, the fact that teamwork was our highest scoring group was also seen in other studies, but then staffing and work pace, which was I think our third lowest, was generally the lowest in other studies that I saw in the literature, as well as in the 2022 database.
Were there any sub-analysis like the ones you talked about in the international studies?
Some papers did have subgroup analysis, but they were, so other studies did, for example, a larger population, for example, like all healthcare workers in a hospital, and then their subgroup analysis would then be focused on like nurses versus doctors versus pharmacists. So it was a little bit different. I don't recall seeing any specifically similar to the ones we did.
Because I find the results quite interesting, also because there's so much difference between the different age groups. Yeah.
Sure.
And that leads me to my second questions, because there's a lot of talk about burnout among healthcare professionals. Did you have the opportunity to look at the correlation between job satisfaction or burnout and these results regarding the impression or the idea about the patient safety climate? Was there some kind of correlation?
Yeah, so unfortunately, there wasn't really like a specific question asking about burnout. Definitely in like the free text responses, we had respondents discussing how they felt like they were overworked. And then I also know there's a different questionnaire, the SAQ, I think Safety Attitudes questionnaire. They recently came out with a new version specifically focusing on burnout post-COVID. But unfortunately, since the new version, they like limited access to it. So it wasn't chosen to be the questionnaire to use for this study.
Maybe for your future research, you would look into that. We've done some work in Denmark regarding counseling in pharmacies. And what we saw is that, because this is very much the core of the task in the hospitals, and what we saw is that if you succeed more with the core of what you think you're supposed to do in your job, then you have higher job satisfaction. So maybe it's a way to look at these things also.
Yeah,
I can see it. Yeah, just an idea.
Yeah.
Victoria has a question for you. She says, thank you very much for your presentation. I find it interesting that you choose to disseminate the survey mostly on social media. Was it possible to calculate a response rate using this approach?
Yeah, so I guess in terms of social media, we weren't necessarily able to see how many people viewed the actual posts, but the response rate came directly from the number of people who actually filled out the Google form questionnaire.
Yeah, so you've done that, but you can't see how many that actually saw No. Good. Thank you very much. Any more questions? Or if you wish to elaborate on anything?
Charlotte, just want to give you an elaboration for the response rate, we did actually look at the number of pharmacists practicing in hospital in Ontario, and there's data about that. And we can actually extrapolate to do the response rate. I think it's about 1%. But again, like to G's point, we don't know how many have seen the survey, to be fair. We just go to the max, which is sort of the number of pharmacists practicing in Ontario. That may not be sort of the fair approach to do the response rate. So to some extent, we can guess the response rate, but then on the flip side is I think it's better to look at the 63 who has responded and see the divide in terms of pharmacists versus pharmacy technicians' response to our questionnaire.
Thank you very much. And do you the distribution between pharmacist and pharmacy technician, is that what you would expect when you look at the workforce in the hospitals? The ratio between the two?
Actually, if we look at the proportion, I don't think it's kind of proportionally fit to the number of pharmacy technicians and the number of pharmacists working in hospital. Because if you look at the stats in Ontario, they're actually not exactly the same as the proportion of our response rate. But I'll let GE sort of expand on that a little bit as well.
Yeah, so in terms of actual numbers of pharmacists practicing in Ontario hospitals and pharmacy technicians practicing in Ontario hospitals, it's about the same. Honestly, I think there's more pharmacy technicians practicing in Ontario hospital. I think it's 3,443 versus the pharmacist is 3,007. So given that, I would say the respondents' proportion of having 3/4 pharmacists, 1/4 pharmacy technicians is not really reflective.
Thank you very much. Are there any more questions? I just need to see. I think she's. Yeah. Thank you for answering the question. Then I would like to thank everybody for this first part of the presentations. Thank you very much to Canada also. And then we will have a break now. So I will see you back here 10 minutes to 3, and we will have the final 3 presentations. Thank you very much, and see you later. Hello, everybody. I hope you have had a lovely coffee break and are back for a few more presentations for this afternoon. We have 3 more very exciting presentations. But first, I would like to just give the word to Ali from FIP that will talk a little bit about the offers from FIP.
Thank you so much, Charlotte. Matthew, I'm going to make you wait a little bit longer. Sorry about that. I would also, first of all, my name is Ali. Some of you know me from the congresses and some of you know me from the webinars. I am the Congress Assistant of FIP. So today what I'm going to talk about is a little bit about the membership and also the Congress. A very short, I promise. So what FIP is offering to its colleagues from the pharmacy practice research is a good deal about the membership. If you are not a member, what we are offering you is to get a 6 months of membership for free, and then get the membership for 2025 also for the price of a 1-year membership. This can be accessed via the link here on the screen. If you can just scan the QR code, you can learn more about how you can become a member using this special feature. It is something I would definitely say that you can consider doing. And Hala, if you can go to the Congress slide, please. You can use that offer until the 21st of July. Please feel free to check it. I am also going to paste the link on the chat so that you can see. And of course, we only have, I think, even less than 2 months left for the Congress in Cape Town, South Africa, which is super exciting for all of us. We've been working really hard to come up with, create the best sessions and best academic program for you, also including some really nice social activities and general events. The theme of the Congress is Innovating for the Future of Healthcare. Personally, as a colleague pharmacist, AI is something I'm really super excited in these days. So there are going to be a lot of sessions about the AI, which I'm looking forward to joining as well. That being said, if you can just go to capetown2024.fip.org, you can learn more about the sessions that we are going to present. And we would all love to see you and welcoming you there. That would be all from my side, Charlotte. Thank you so much. And I would also like to thank Victoria and Fernanda as well, and all these beautiful participants for joining and making this event something memorable for sure. Thank you so much.
Thank you very much. And for all of the participants, I would like to say that we are just trying to facilitate it. This would never happen if we wouldn't have the support from the FIP headquarters and from Ali and the rest of the team. So thank you very, very much. I will move forward now to the next speaker. That's Matthew DeMarco, and he's a full-time PhD student and clinical pharmacist that works in the Kitchener, Ontario, Canada. Matthew's contribution to pharmacy practice research to date consists of publishing a scoping review and conducting qualitative research methods as part of his PhD work, as well as additional research projects into Ontario Pharmacy Evidence Network, OPEN. Matthew's PhD work looks to evaluate pharmacy workflows as it relates to impacts of the expanded scope of practice for pharmacy technicians administering injections in community pharmacies in Ontario. Matthew's current and past clinical practices include transport medicines, critical care, primary care, and interdisciplinary clinics providing care to patients with diabetes, chronic pain, mental health, HIV, and HCV. Thank you very much and welcome, Matthew.
Thank you, Charlotte. I'd like to extend a huge thank you to our audience for joining us today, FIP, PPR SIG, in addition to my supervisors, Dr. Waite and Dr. Houle, for their support that they provide day in, day out for the research that we complete together. So moving over to our next slide on conflicts, no conflicts to declare. We can now move on to a little bit of background. So community pharmacies have demonstrated their role as accessible vaccination hubs, yet pharmacists' prioritization of dispensary and clinical activities may limit their ability to offer vaccinations during their busy day. To meet increasing patient vaccination needs, pharmacy technicians can be an important member of the vaccination team by screening prospective patients for eligibility and providing injectable administration to support vaccination, which is what the image and citation on the left-hand side of the screen signifies from a scoping review that our group published back in January 2022 that looked into the role of pharmacy technicians in vaccination services. The scoping review also found that involving technicians in vaccination administration in particular was also found to have consistently positive outcomes related to patient care and patient outcomes, training, in addition to workflow, and more specifically, speaking to workflow, improving pharmacists' time, improving overall efficiency of the pharmacy, and the trialability of the technician injectable role was quite easy to adopt. So since just over 3 years ago, when we were working on the scoping review, and there was only one country with the expanded scope for technicians to administer vaccines in the US, led by Dr. McKiernan, and under pharmacist supervision and specific technician certification and training for injection, there are now 17 countries with the expanded scope for technician vaccine injectable administration, which demonstrates rapid uptake across low, medium, and high income earning countries as defined by FIP. Canada is one of the 17 countries, with 6 provinces possessing the expanded scope for technician injectable administration. And when it comes to which type of drugs, some provinces say all injectable products under the pharmacist scope, and some provinces name COVID vaccines, influenza vaccines, or RSV vaccines, or like it's named here in Ontario, it's some combination. So it's technicians here in Ontario are able to administer COVID vaccines, influenza vaccines, and RSV vaccines. Okay, and once again, in a similar manner that Dr. McKiernan piloted this intervention with special injection certified training and under pharmacist supervision. Also worth mentioning when it comes to types of pharmacy personnel here in Ontario, Canada, pharmacists and technicians are both regulated and licensed pharmacy professionals, whereas assistants are not. Although technicians and assistants often have a college degree to support, or often have a college degree or university degree to support their training, only regulated or registered technicians must complete a 24-month curriculum in addition to a licensing exam to become regulated and licensed. So moving to the far right and bringing us to today's work here in Ontario, with 1 in 4 technicians certified and have taken this special training and certification course, we thought that this was a good geographical region to ask research questions that were aligned with the scoping review's conclusion and future work, which stated that there was no research currently that looked into the collection of pharmacy members' roles in the vaccination workflow in regional jurisdictions that have the expanded scope for injection. And hence the aim of our work was to identify and describe best practices for technician vaccination workflow in community pharmacies in Ontario, Canada, and was guided by the following 3 research questions. One was looking into who was doing what in the vaccination workflow across the pharmacy team. So you kind of see that alluded to on the far left-hand side, which was part of the conclusion of the scoping review. But also, what are the influences of the vaccination workflow, and what are the overall outcomes on the vaccination workflow of bringing an injection certified technician into the workflow? We can move on to the next slide. So we answered these research questions through employing semi-structured interview methods with pairs of injecting registered pharmacy technicians who had administered at least 40 vaccines and pharmacists practicing at the same pharmacy. Interviews were virtual and 30 to 45 minutes, and questions were mapped to the System Engineering Initiative for Patient Safety Theoretical Framework, or SEAPS 2.0. Examples of questions are the following: who is involved at each step of the vaccination workflow? Can you recall situations where your usual workflow for vaccination was not followed? And how has integrating an injection registered technician impacted the vaccination workflow outcomes? Okay. So sampling targets for this study were for this qualitative study were 6 to 12 pairs and depended on codebook saturation. Reflexive journaling, member checking, researcher triangulation, iterative meetings were performed to establish consensus coding in vivo and Excel using Braun and Clark's thematic analysis. We can move on to the next slide. So moving over to some results from the 10 pharmacist technician pairs that were interviewed. First, we have some pharmacy characteristics in the middle. 7 of the pharmacies were in an urban region, whereas 3 were in a rural. 4 were mass merchandisers, 4 were chain, and 2 were independent pharmacies. Relative to daily prescription volumes, 5 of them had less than 400, on average 400 prescriptions per day, and 5 of them had 400 or more prescriptions per day. Relative to historic vaccination offerings, 9 of the stores had established vaccination programs for more than 5 years or more, whereas only 1 store had a newer vaccination service offering, or the first vaccination service offering in their store. And all of the stores offered meds checks, reviews, and minor ailment consultations. Moving over to participant characteristics, thank you. Moving over to participant characteristics, average age was 42 years, and the age ranged from 27 to 59. Average years of experience was 14 years and ranged from 3 to 32. COVID or influenza vaccines injected per day by the technician during high volume times averaged 84 vaccines per day with a range of 18 to 20, and during low volume times averaged 3 vaccines per day and ranged from 0 to 5. We move on to the next slide. Influences of the vaccination workflow was one of the major themes found in our analysis, with operational influences shaded in gray, which were influences that were used to directly describe exactly how and when the vaccination workflow was delivered. And this helped discuss a little bit of the variability involved in some of these operational influences indicated in gray, and which workflow model or what assembly of the workflow model or which workflow model could be optimal. Non-operational influences were a little less directly involved in the description of how the workflow was delivered, and either had to do, and they're shaded in white, and either had to do with indirect resources and influences such as technology, cost, or physical space, as well as the other theme for non-operational influences down at the bottom were patient needs, which had to do more with learnings or experiences with patients that were then applied in the future to improve their patient-centered approach to providing vaccinations. Okay. We can move on to the next slide. Results from our qualitative analysis also describe 2 workflow models that were used by almost all pharmacist technician pairs that were interviewed. The first model you see here was the high efficiency themed workflow model that was used for when the following operational influence is presented in the bottom left. So for when there are high vaccination volume times as a key influence that's highlighted in blue, but also when the appointment-based model was available, when pharmacy staff was available, and particularly pharmacy assistants, and when there were lower dispensary volumes more specifically. Role allocation among the pharmacy team was characterized by assistants completing intake and monitoring, and while the technician administered vaccines in the designated room or injection area continuously, and while the pharmacist provided clinical verification, answered patient questions, supported the technician or assistant in the workflow, treated adverse events, or managed the vaccination workflow and adapted it. Okay. Also wanted to note that the pharmacy assistant intake roles more specifically involved in the top left-hand corner, completing consent and eligibility forms, order entry, vaccine registry completion, as well as billing. Okay. In explaining why this model was used and its overarching theme and name, it provides increased efficiency of the vaccination workflow as explained in the above quote in the middle bottom. So the assistant on the beginning portion really did help move things along, and then just moving to the right, they, the technician, were just sitting in the counseling room for 8 hours, just going to be injecting. Increase in efficiency was also indicated by the appointment booking interval times for the appointment-based model, described by almost all pairs of 5 to 10 minute appointment intervals. And another really important outcome that was associated with this model, but a little bit more indirect, was that participants found that when dispensary volumes increased, this model was challenged, and their perception was that there was a negative impact on dispensary support when dispensary volumes increased concurrent to using this model. We can move on to the next slide, please. So the next model to discuss is called the Flex and Protect model. And this model was described by all pharmacist technician pairs in that it provided flexibility for the workflow. And it was used in the following circumstances of operational influences in the bottom left-hand corner. Once again, low vaccination volumes as a bit of a key influence, but also when there was appointment-based or intermittent appointment-based or walk-ins appointments that were offered. If there was also staffing shortages, scarcity, or sick days, as well as if there was a high dispensary volume concurrent. Those are some of the operational influences that called for this model. Role allocation among the pharmacy team was characterized by the technician completing patient intake roles, vaccine administration, monitoring, and then that left the pharmacist maintaining the same roles as in the last model with clinical verification, answering patient questions, supporting the team, treating adverse events, and managing the workflow. In explaining why this model was used and its overarching theme and name, it provided flexibility to the technician's time in both the vaccination workflow and the dispensary intermittently, and worked to protect the assistant and pharmacist working in the dispensary, as exemplified in the quote in the middle bottom. Taking care of all the vaccine steps, I think that reduces some of the stress for the rest of the staff. The less people involved in the vaccines, the better, because that's more people on the front lines with prescriptions. Another consistent outcome associated with this model, worth mention, and in contrast to the high efficiency model, was that it actually reduced efficiency, which is indicated by the appointment booking intervals on the left-hand side of 10 to 20-minute appointment booking intervals, or appointment times for walk-ins described by the majority of interviewed participants. And this is also indicated by the quote over on the right. With this model, we get, as one technician explained, with this model, we get behind without an assistant. That way was very difficult because when I was finishing with someone and coming out to get the new paperwork, then I would have to check on the people in the waiting area, give out their piece of paper that said they had their shot, then bring my next person in. So it definitely slowed things down. So hearing some of that pressure of losing the assistant on the front end, who's now, as you can see on the top left-hand corner, working in the dispensary, losing that assistant who's kind of queuing up the whole vaccination workflow model for each patient, and this technician definitely feeling some of that pressure. We can now move on to the next slide. So now moving on to some overall workflow outcomes involved with bringing an injection certified technician into the workflow and not necessarily assigned to a high efficiency model or a flex and protect model. First, at the top in maroon, we have the workflow outcome sub-theme of pharmacy professional motivations, with pharmacists being motivated by a lower stress environment and getting help from the technician with their overall pharmacist-only workload. Technicians were motivated by their experiences because they were finally getting a chance to leverage their advanced skill set that they were trained for, and when it mattered the most to the pharmacy team and their patients, as one technician described in the top right-hand corner. It gives you a pep in your step. And I say that in the nicest of ways during one of the worst crises we've probably ever seen in our lifetime. Moving to the bottom right in green, pharmacist-technician pairs consistently explain sub-themes of increasing pharmacist time and flexibility. As one pharmacist explained, it definitely helped me a lot to do more clinical services and gave me time to answer questions and definitely helped with the overall workload. In the bottom left-hand corner, in purple, we have the workflow outcome sub-theme of increasing patient access and safety while providing positive patient experiences, as exemplified by one technician's words. It definitely allowed me to take in more appointments, take in more walk-ins, and definitely reduce wait times and stuff like that. Last in the middle, in yellow, in the top left-hand corner, we have an increase in injector availability and overall increase in vaccinations administered, as exemplified by one technician in the top left-hand corner. If I, technician, wasn't able to jump in, there's no way we could have expected the only pharmacist or one or two pharmacists to drop everything at that moment and take a couple walk-ins. Okay, we can move on to the next slide. So just a couple discussion points to touch on as we wrap up. First, discussion point reads, use of an injection certified pharmacy technician increases injection capacity and optimized pharmacy team member roles to best use their skill set and assigned responsibilities. This discussion point contributes to the body of literature by Dr. Shane Nussel and Dr. Kim McKiernan that discusses the importance of pharmacy support workforce cadres of technicians and assistants that undertake technical tasks delegated under the pharmacist's supervision and perform collaboratively in efforts of improving and advancing patient care and pharmacy professional practice models. The second discussion point reads, community pharmacies should consider a variety of influences such as vaccine volume, team member skills, staffing, and dispensary needs when choosing vaccination workflow models. Model use should be dynamic and should accommodate changes within the workflow, should accommodate changes within those influences. And this bullet builds onto the work of Dr. Kenneth Hohlmeier starting back in 2019, 2021, 2022, with the optimized care model that explains the impact of task delegation as a pathway to increasing patient care, in that this work names specific influences or conditions or variables that are dynamic and require our understanding to attain optimal task delegation of both clinical technical roles and non-clinical technical roles. So just kind of giving us one more layer of perspective on Dr. Hohlmeier's work. And last to mention, future research is required that quantitatively compares technicians to pharmacists' injector workflow models relative to time, as well as resource costs overall. We can move on to our conclusion on the last slide. Use of injection certified technicians resulted in workflow models that optimize use of pharmacy staff skills and manage patient volumes while considering dispensary planning and staff. Community pharmacies utilizing injection certified technicians can offer safe and effective expansion in access to vaccination services. And once again, I think that this highlights some of the significance of this work in providing some guidance for early adopters, given that there's been rapid uptake of this role from a global perspective in supporting policy change and new practitioners as they step into that space with what are some best practices to consider. With that, I'd like to conclude our talk for today and welcome any questions. It's once again such a pleasure to be speaking to this group today regarding this work featuring injection certified pharmacy technicians. Thanks, Charlotte.
Thank you very much, Matthew, and thank you for your talk. Wonderful to see the documentation of pharmacy technician and pharmacy assistant and pharmacist working together as a pharmacy workforce. I think that's crucial in the times ahead. We have a question. What was the rationale for offering money to the participants? Do you think this might have introduced a bias into the research?
I would agree that there is a potential for introducing bias with both the incentive provided, and I'll also add at this point in time, disproportionate, well-established practices and self-selection of those that wanted to be interviewed. So it might be a slightly disproportionate sample in that regard relative to the external validity and our current practices today. Although I will say that offering the incentive is aligned with current best practices for researching in a patient-centered focus of ensuring that there are benefits to the participants. Great point, well taken, and I'll definitely give that some thought as we move forward and how that places our results exactly. Thanks.
Yeah, thank you very much. It is true, it is a potential bias, but also a necessity if you need people to participate and actually acknowledge that they use their time on this. So thank you very much, Matthew. Do we have any more questions? I can see one more coming. Thanks, Matthew. Great presentation and valuable research. My name is Joel. I'm a pharmacist and postdoctoral researcher in digital health in the Centre of Digital Transformation of Health in the University of Melbourne, Australia, and a member of the FIPTech Advisory Committee. My question is, during your research, did the idea come up that some pharmacists might oppose this model? Specifically, was there any concern that hiring more pharmacy technicians for vaccinations at a lower cost could reduce the demand of hiring pharmacists?
So definitely the latter comment is the pursuit of this research, and that's what we're going to take on with the Tide Motion study. That's looking at exactly the cost differences and making that case for the cost advantages or cost containment advantages of using a technician instead of a pharmacist. But back to your point about excellent point about disseminating this research and pharmacist opposition. And I think that's an excellent question to ask about this research. And we've been so lucky that Dr. McKiernan has actually looked into this question quite a bit in some of her publications, which were included in our scoping review. And what was interesting when it came to pharmacists adopting this new practice is what they found was that because it was so easy to trial in the workflow and observable, pharmacists were able to, let's say, get over that barrier or that hesitancy very quickly once they were able to observe that the technician was able to do this confidently and safely for the patient. So in summary, I would expect opposition, but the good news is that with the actually seeing that it can be done in a safe manner very quickly, pharmacists establish some confidence around that and are able to adopt it. The other piece is with increasing training being available, there's also been shown to also reduce the barriers of some of that hesitation to take it on. So with training and with observability, trialability, it's anticipated that many pharmacy professionals will find it adopting this advantageous to their practices.
Thank you very much, Matthew. And we'll move on to the next speaker now.
Thanks, everyone.
Thank you. So this is Alexander Kondrashov, who graduated with honors from the Faculty of Fundamental Medicine in the field of pharmacy at the Moscow State University, after which in 2022 he enrolled as a postgraduate in the postgraduate program specializing in pharmacoeconomics and organization of pharmaceutical businesses at the same university where he currently continues his study. Alexander combined his study with work in medical, pharmaceutical, and telecom companies as a software developer and data analyst. Currently, he has more than 3 years of experience in the field of medicine and data sciences. The main direction of his research is to explore the possibilities of using data-driven methodologies and big data analysis to solve problems and tasks of pharmaceutical practice, such as creating effective personalized drug insurance programs, as well as ways to optimize and increase the availability of pharmaceutical care for children. Thank you and welcome, Alexander.
Good afternoon. Good afternoon, dear colleagues. So what about my presentation? Could you please move back? Yes, thank you. Today, I would like to present you my research entitled Influence Assessment of the Characteristics of Doctors and Patients on the Effectiveness of the Predictive Machine Learning Model in Prescribing Drugs to Children. Next slide, please. Sorry, I didn't pay enough attention to creating a separate slide to indicate the absence of a conflict of interest, because our study has no conflict of interest. And it's not a secret that almost every study is interdisciplinary. And sciences such as medicine and pharmacy use computer and digital technologies as research tools. So, for example, specialists in computational linguistics to develop chatbots return to the good old rules of our native languages or work in cooperation with linguists. Such patterns encourage business to invest in artificial intelligence technologies, especially in everything related to healthcare. This is why, according to reliable analytical agencies, the market size of the artificial intelligence in healthcare or med AI technology field by 2030 will be almost 7 times larger than it is now. Business and science, as we know, set new trends and directions for each other, for the development and creation of new scientific research. The next slide, please. Thank you. Many of you have ever used streaming music services or watched videos on popular video hosting sites. After registering or logging in, specifying your personal data and watching several videos, such services begin to give you recommendations based on your experience on this platform and your characteristics. You watch what you like, or rather what people like you like. People who have similar geolocation, lifestyle, habits, may have already watched the video that you planned to watch next. This is exactly the essence of this kind of machine learning models, to find the most suitable recommendation for you so that you stay in this platform and return to it again. It is this so-called habits or characteristics of doctors and patients that we identify and study in our research. So we assessing the impact on the result accuracy of a predictive machine learning model prototype using the pre-developed accuracy metric. We also identified 3 main questions that need to be answered clearly. The first 2 are related to our research, and the last one mainly reflects the essence of one of the practical applications of our product. Could you please move on to the next slide? Thank you. A few words about the roadmap of our work. The research block on the slides reflects the main point of what we are doing as a part of our research. Important stages of data preprocessing and data integration, as well as feature extraction, are necessary to create an effective machine learning models. The development block is the potential future of our project, which we see as the software with the functionality of predicting the most likely outcomes of prescribing a particular drug to unique patient, adapted to various scenarios of its use. Next, please. Thank you. To create a prototype of the machine learning model, tools and technologies were used that correspond to the best development practice in this area. There are Jupyter Notebook as a development environment, methods of the Python programming language and its pandas library for data preprocessing, scikit-learn and Keras TensorFlow application programming interface for prototyping machine learning and deep learning models. And Selenium WebDriver is used as a web scraping instrument to collect data and make the drug's price data set from public sources. The model was developed on the basis of a database of drug prescriptions. It is the data from the electronic health records database provided to us by a network of private clinics for children. This database contains records for the period from January 2018 to January 2023. The data schema contains columns with data on patients, doctors, prescribed medications, date of visit, and diagnosis. Later, the columns such as the patient's age, specialization, and name of the doctor, as well as the date of the visit, were identified by us as a key characteristics that directly affect the accuracy of the prototype of our model. Next slide, please. Thank you. As a result, we present you the answers to the questions that arose in our goal-setting process. Firstly, a reliable formula for evaluating the effectiveness of the developed model for predicting drug names was established. Its meaning is to determine the proportion of correctly predicted drugs compared to the data of the test sample. The accuracy of the model increased markedly when we added to the model the ability to take into account the fractional age of a patient, the date of prescription of the drug, as well as the specialization and encrypted name of the doctor. They act as those indicators, the key characteristics that we outlined in the second question of our goals. Here, the naive method of prediction is to sort the data of prescribed drugs in descending order of their frequency of prescription and push them to the output of this model. And the final algorithm for determining the cost of pharmaceutical care, it's a feature of our research. We can see it in the diagram on the slide. It consists of key characteristics from dataset. and training models of the above architecture based on the data obtained, and then combining the results of the model with data on consumer behavior and the cost of drugs to subsequently obtain a ready-made price offer. In fact, it was this scheme that formed in the very beginning of our developments as a kind of potentially effective way for practical application of our products in business. Next slide, please. Thank you. The accuracy of the obtained algorithm is almost 2 times greater than that of the naive model. We are also continuing to work on optimization, on optimizing the loss function and identifying new key characteristics to improve the accuracy of our model. The developed models can serve as an important tool for optimization of pharmaceutical care, as well as for the development of drug insurance programs for children. We would also like to point that we do not neglect possible ethical issues. François Chollet, creator of the Keras TensorFlow library that I used in my developments, discusses the ethical issues of developing machine learning, deep learning, and artificial intelligence methods in his book, Deep Learning in Python. He emphasizes the importance of developers' responsibility for the impact of AI on society. Chollet also notes the need for algorithms to be fully explainable, and also focuses on the problems of bias in data and algorithms that can lead to unfair results. As well, the need to develop AI in accordance with the principles of justice, equality, and respect for human rights. We believe that an effective drug insurance system helps to increase the availability of pharmaceutical care for children. And also it can help reduce the financial burden on our families and make the outpatient treatment process more effective. We also believe that our developments can help this. So our future plans again is the development of a software prototype, the functionality of which is aimed at determining the cost of pharmaceutical care and the configuration of an individual drug insurance offer for children. Next slide, please. Thank you very much for your attention and for the opportunity to share the results of our research with you. I would be very glad to answer your questions.
Thank you very much, Alexander, and thank you for sharing your research in this new and forthcoming area of AI and big data. So thank you very much. I'd like to open for the floor. Do we have any questions for Alexander? Just give it a few minutes and see if we get any, or maybe at the end we will see some questions. I don't think so, Alexander, but stay tuned. There might be a few questions by the end of the presentation today, and then we will take it there. So thank you very much, Alexander. And then we will move on to the final speaker of today, Animi Ishit, which is a clinic pharmacist and a senior lecturer at the Department of Clinical Pharmacy at the University of Oyo in Nigeria. He is also a consultant public health pharmacist and fellow of the prestigious Western African Postgraduate College of Pharmacists. He has completed over 50 WHO organized trainings and public health interventions. He's the founder of eMediconsult Ltd, a healthcare service delivery organization poised to promote health and improve the quality of life for every community they serve. Doctor is a member of the International Executive Council of Clinical Pharmacy Association of Nigeria, a member of the Association of Public Health Pharmacists of Nigeria, and also a member of the International Association of Public Health Logisticians. He is the assistant editor of Nigerian Journal of Clinical Pharmacy and Therapeutics. He is also a member of the editorial board of CPQ Medicine Journal. Dr. Ishit is an elsewhere academic certified peer reviewer and peer reviewer of several international journals. He has several years of experience in clinical pharmacy practice with keen practice and research interest in rational use of medicines and public health interventions. He has authored 3 academic books and has several research publications in higher impact peer-reviewed journals. So please, we look very much forward to hear your presentation.
Okay, thank you very much. Thank you very much. Good afternoon, everybody. I hope you can hear me clearly.
Very good, thank you.
Thank you. Thank you very much. And my name is Sunyime Shit, and I'm going to speak on the research that we titled Impact of a Pharmacist-Led Infodemic Management Intervention on the Perception, Willingness to Receive, and Willingness to pay for adult vaccines among civil servants in Nigeria. Next slide, please. So first of all, we declared that there was no conflict of interest among the researchers in this study. Next slide. So adult vaccines remained largely underused, leaving adults in Nigeria particularly at risk during disease outbreaks due to a lack of immunity. The pervasive influence of misinformation and disinformation regarding the use of vaccines promote vaccine hesitancy among the adult population in Nigeria. So this poses a great public health risk. Next slide. So during the last decades, pharmacy, as we all know, have shifted from being product-based to being service-based and patient-centered with the advent of clinical pharmacy and pharmaceutical care. So despite the non-pharmacological nature of public health policies, hospital and community pharmacists continue to play and are still playing a key role in the containment and management of vaccine preventable disease crisis. So pharmacists can serve as educators, can also serve as facilitators, and in some jurisdictions, pharmacists can serve as vaccine administrators. Next slide. So the aim of our study was to evaluate the impact of a pharmacist-led infodemic management intervention on the perception, willingness to receive, and willingness to pay for adult vaccines. Next slide. So our method, we used a cross-sectional interventional study. It was carried out among civil servants in Akwa Ibom State, which is one of the states in Nigeria. So we used a pre-tested interviewer-assisted questionnaire, which we administered among staff of the Akwa Ibom State Local Government Commission. What we did was we selected 3 local government among 36, and the 3 each, we have 3 senatorial districts in Akwa Ibom State, so we selected 1 local government per senatorial district. So the questionnaire assessed the perception of the respondents toward vaccination. It also assessed their willingness to receive the vaccines and also their willingness to pay for these vaccines. Next slide, please. So a pre and post evaluation of the respondents was done before and after an on-site public health enlightenment intervention on adult vaccines. And this intervention was implemented by a public health pharmacist. So before the intervention, there was an evaluation of their perception and their willingness to receive and pay for the vaccines. And after the intervention, a follow-up evaluation was done to see if there was any change in their perception, their willingness to receive and pay for the vaccines. So we analyzed using the IBM Statistical Program and Service Solutions, version 25. And inference statistics was used student t-test and a person's chi-square test were used to test differences between the pre and post evaluation data, and our statistical significance was set at p less than 0.05. Next slide, please. Next slide. Okay, these are our results. We actually interviewed, no, previous slide, please. Previous slide. Okay, we actually interviewed after this one, the next one. Okay, we actually interviewed 419 civil servants, which we put into the study. However, only 377 completed the study. 419 were part of the pre-evaluation, and only 377 of the 419 completed the post-evaluation. And the demographics of the participants is presented in the next table. Next slide, please. So I said earlier, we used 3 local government areas, and Ikot-Ekpene, Oron, Uyo local government, which are districts in Akwa Ibom State, and 41%, about 41%, which is the highest, was in Oron local government. So the age range, we had predominantly people from 40 to 49 form the highest percentage of the population at 86.75. Then gender, we had about 73% females in this study. Then at the educational level, majority of them, 87.59%, were people who had completed tertiary level of education. Next slide. Then the state we carried out the study was a highly predominantly Christian state. So we had about 99% Christians in this population. And then as per their income, 72.55% of the population reported that their income, that is their monthly income, was not sufficient for them. And only about 8% were enrolled into the National Health Insurance Scheme, which is a health insurance scheme provided by the government. Next slide, please. The respondents' experience with adult vaccines. So we asked the questions, we asked, has vaccination ever been recommended for you in your adult age? 87% of our respondents said yes. So we now follow up with if yes, who recommended the vaccine? So a majority of them said the vaccine, 32% said they were medical doctors that recommended the vaccines for them, while 22% said the community health extension workers, 18% said they were recommended vaccines were recommended by nurses, pharmacists, 13%, and non-healthcare professionals, about 13.7%. So we now asked, did you receive the vaccine as recommended? Only 71% out of the 365 people that said yes, they were at one point in their lifetime they were recommended adult vaccine. Only 71% said they had actually received the vaccines. Next slide, please. So we asked now, why did you not receive the vaccine? What's the reasons why you did not receive the vaccine as recommended? They said the reasons they gave was they were afraid of the side effects. Some of them said that they don't believe that vaccine actually prevents diseases. Some of them felt that vaccines were only for children, not for adults. And some of them said because of their religious belief that it forbids them receiving vaccines. Next slide, please. So, participant willingness to receive and willingness to pay for adult vaccines. Before the intervention, about 87% of our participants expressed willingness to receive adult vaccines if recommended by healthcare providers. A total of 262, that's about 62% respondents were willing to pay for adult vaccines, while 37 respondents were unwilling to pay for adult vaccines. The mean amount of respondents were willing to pay for their vaccines, if recommended, was 552, which is about 36 cents in the US currency. Next slide, please. So a further inquiry into the amount each respondent was willing to pay, that is, among those who were willing to pay, when provided with a price range, showed that about 66% of the respondents were willing to pay less than 500, which is less than 36 cents. And while only 10, about 4% of the population were willing to pay about 2,000 and above, which is about $1.30 or thereabout. Next slide, please. So among the respondents who were unwilling to pay for adult vaccines, no, previous slide. Among the respondents who were unwilling to pay for adult vaccines, 45.22% said they were against paying for vaccines. Some of them said that they cannot afford to pay for vaccine because of their low income, and many of them believe that healthcare services, including vaccination, should be provided free by government, while 22 said they said that they don't need vaccination. Next slide, please. So in the first phase of the study, we said earlier 419 participants were interviewed. However, following the implementation of the pharmacist-led intervention, only 377 participants participated in the post-evaluation. So we now looked at the impact of this intervention on their perception and willingness to receive and pay for the vaccine. Next slide. So we found that there was a statistically significant difference in the mean perception score of the participants pre and post-intervention. The pre-intervention perception score was 5.713 versus post-intervention 6.679. And of course, it was statistically significant when we ran the analysis. And an item mean perception score of respondents before and after intervention, and the test of difference is presented in the next table. Take next slide, please. So this table shows the questions that we asked and their score pre and post intervention, as well as the level of significance of the difference between their scores. So the question we asked, do you believe that vaccines protect humans from serious diseases? Do you believe that vaccines prevent the spread of disease from one person to another? Do you believe that vaccines are safe and effective when used as recommended? In most cases, side effects associated with vaccines are mild. Do you believe that the benefits of vaccines far outweigh the risk associated with them? Next slide, please. We also ask, will you allow your children or your child to receive routine vaccines? Do you think it is necessary for adults to get vaccinated? So from this table and from the analysis we ran, we found that, yes, the intervention provided by the public health pharmacists significantly improved their perception. Next slide, please. So the impact of intervention on the respondents' willingness to receive and willingness to pay for. So there was an increase in the number of respondents who were willing to receive the vaccines between the pre and the post-intervention period. However, we found out that this was not statistically significant. However, there was an increase. Pre-intervention, 328 were willing to receive. Post-intervention, 343. Yes, it was an increase, but it was not statistically significant. Next slide, please. So there was also a statistically significant difference in our respondents' willingness to pay money to receive vaccines recommended by healthcare provider. However, there was no statistically significant difference in the amount of money the respondents were willing to pay. Yes, the intervention significantly improved the willingness to pay, but it did not improve the amount of money they're willing to pay. So we said, are you willing to receive vaccines if recommended by your healthcare provider? Yes, 328 said yes, 343 in the post-intervention increased by about 20-something. Then, are you willing to pay money to receive vaccines if recommended? Yes, 200 people said yes, and 241 said yes after the intervention. So if your answer is yes, what is the maximum amount of money in Naira that you're willing to pay? So, before the intervention, they agreed 601 was the average amount they maximally pay, while after intervention, 712 Naira. Next slide, please. So we went ahead to provide them a price range from less than 500 Naira to greater than or equal to 2,000 Naira. Yes, they think it improved, but it was not statistically significant. Next slide, please. So we concluded by saying that the pharmacist-led infodemic management intervention had a statistically significant positive impact on the respondents' perception and willingness to pay for adult vaccines. And we then went on to finalize by saying that infodemic management interventions can effectively improve uptake of adult vaccines. Thank you for listening. These are my next slide shows my references. I'm open for questions and contributions, if any.
Thank you very much for your very important talk on this very important area. Do we have any questions? We'll just give a few moments to see if we get any questions in the Q&As. While we wait, I don't know if Federico is still here. We have a question for him from when his presentation was on. Is Federico here? Can you see that, Ali?
Federico had to left after his presentation. He informed us about that.
Okay, no worries. Then I think we have finalized the session for today, and I'd like to thank all the speakers, and I'll give the word back to Victoria, the chair of the FIP SIG for Pharmacy Practice Research. Thank you, everybody.
Thank you.
Thank you very much, Charlotta, for moderating this interesting session, and thank you very much to our wonderful speakers. We've had the opportunity to listen to excellent researchers from across the world, including Spain, Canada, Austria, Russia, or Nigeria. So I hope you have enjoyed them. It is very exciting to see the large variety of topics covered, including implementation, academic leadership, competency frameworks, data science, vaccinations in different settings where pharmacists can practice, including community or hospital, research which undoubtedly contributes to the advancement of the pharmacy profession across the world. Please do not miss the opportunity to check the virtual posters available on the events website. Just some information, more than 70 posters have been received, which you can check, and contact details of corresponding authors are also available on the posters. As a final note, certificates of attendance will be provided by early next week. Please be reminded that we have a second session tomorrow where 7 wonderful speakers will be sharing their research again. So again, thank you for your participation in this event, and we hope to see you all again tomorrow. Bye.